Welcome to you all. We're so very glad you're here. And I want to start by acknowledging our presence here tonight as uninvited visitors on the traditional, ancestral, and unceded lands of the CF Okanagan people who resided here, stewarding this land and everything that lives and interacts on it since time immemorial. And in making a land acknowledgement to reflect on this complex aspect of our country's past, present, and future, we also want to draw on the wisdom of the elders within our community to guide us in meeting here tonight in a thoughtful and respectful manner to deal with sometimes difficult topics in a good way, in a way that includes all of us as valued participants in a collective journey of discovery. For those of you who are online in this virtual space, and there are many, I want you to know that we're so glad you have joined us, even if we can't see your faces in our midst. It'll be our task tonight to find ways to engage all of us present as we reflect on a topic that is profoundly shaping the conversations that Canadians are having about the meaning of life and death, about illness and suffering, and about enacting choices in the paths we take as we journey toward the end of our lives. So to set the stage for what will happen this evening, I'll introduce myself. I'm Sally Thorne. I'm a registered nurse and a researcher based at the UBC School of Nursing in Vancouver. And I feel so fortunate to be part of the research team that is hosting tonight's event. Our gathering is funded by the Canadian Institutes for Health Research as a means by which to share information with the public that is factual and current, and to give you an opportunity to be updated on what we're finding in our research and our practice on the issues surrounding medical assistance in dying. This cafe is not designed as a place for debate or for arguing different positions and opinions around MAiD. Instead, it's an opportunity to learn and ask questions. And as we begin, I want to ensure that we all recognize that there will be people in this room today and in the online space who've come to this conversation with varying perspectives and experiences on this topic. There will be people here who are struggling with the idea of medical assistance in dying, or may be considering it themselves, or who may have family members or close friends who have died in this way. Our commitment is to maintain respect for everyone present as we progress through the evening. Soon you'll be hearing from our invited panelists, people who have all been involved in the research and practice in medical assistance in dying, and they're all seated here at the front of the room. I'll introduce them one by one and ask them to wave their hands so you know which is which. First, we have Verigin, who is a nurse practitioner in interior health based in Castlegar. Next, we have Dr. Barbara Pesut, who is a researcher on faculty here at the UBC Okanagan School of Nursing. And she was awarded funding by the Canadian Institutes of Health Research to host this cafe gathering. And beside her, we have Dr. Caroline Variath, a researcher and faculty member at Vancouver Island University in Nanaimo. And next to her, Dr. Janine Brown, who is a researcher and associate dean in the Faculty of Nursing at the University of Regina. And last but not least in the panel, Laurel Plewes, who is an advanced practice nurse and holds the position of MAiD coordinator for Vancouver Coastal Health. So that's our panel. And to explain the agenda for tonight, each panelist will give a brief talk, one by one, and the talks will be followed by a short break after all of them to deal with any biological functions. You've found where the washrooms are, I presume, and allow you to gather your thoughts for the question and answer session. And so that you'll be well prepared for that part of the evening, I'll explain how this will work for both those of you in the room and those of you who's joined us online. The main way you'll be submitting your questions to the panel to consider will be through what's called a Slido app, and you have information about that in your bags. It's available on the various devices you may have with you. Some of you may have cell phones or laptops at slido.com. And if you're here in person, the Wi-Fi login can be found in a paper on your bag. And however, we know not all of you will feel comfortable with this newfangled way of submitting questions. And so we have alternatives. For those of you who are online, you can write your questions in the Zoom chat, and one of our helpers here tonight will copy it into that Slido for you. If you're here in person, you can actually write your question down in the old-fashioned way in paper and pencil. And when we provided the paper and pencil in your bag, and one of our research assistants will come around and pick those up, or you can bring them to the box at the check-in during the break. So as you listen to the presentations, think about what questions you might have so you'll be ready to submit them using whichever technique you prefer. And if you aren't able to submit questions, you'll still find it interesting and valuable to listen to the answers of the questions that other people raise. We won't get to all of them, but we will take them seriously. And I'll give you a reminder of how we're going to do this when we get to that part of our program. So for now, let's move on to our speakers, and we'll start with Laurie.
Okay. Well, first of all, let me say how nice it is to be here and to be in a room full of people again. It's kind of been a minute since we've been able to gather. My job tonight is to speak to you as a prescriber assessor and to cover off some of the things that are important to consider during assessments, and to reassure you that the systems in place are in fact comprehensive and quite rigorous, despite what you might actually hear in the media or have heard from your neighbor or someone across the street. So I want to, first of all, get a few acronyms out of the way, because there's lots of jargon when we're talking about MAiD. And tonight our focus has been mostly on what we want to call the track 2 patient, the patient or person who has a death that is not reasonably foreseeable. But I'm going to cover the eligibility criteria and what actually makes a person eligible to apply for MAiD and qualify to have a medically assisted death. This is the law, and this law is consistent across the country. What may be different is how it is monitored in each province, who's collecting the data, how each health authority organizes itself. But when it comes down to the criteria, this is the law across the land. So the processes are really patient-centered, they're thoughtful, they're rigorous, and they often involve a great deal of time on the part of the assessor. It's really important to remember that the assessor and provider are doing their best to meet the needs of the patient, and that any conversation about medical assistance in dying is rooted in what I like to refer to as the goals of care when we're talking about the end of life. This conversation should ideally start with the primary healthcare provider, but in many cases, unfortunately, it often doesn't. But when me or one of my colleagues is assessing someone who has made a request for MAiD, you know, this is very important to us that these conversations are rooted in what are your goals of care. So let's just, move on to a couple other things. Let's talk a little bit about what needs to happen to be eligible for MAiD. First of all, you have to be 18 years of old or older. You have to also be eligible for healthcare benefits in Canada. The reason for that is that Canada did not want to become a tourist destination for people seeking medical assistance and dying. It's also important to understand that people must have a serious, incurable disease, illness, or disability that is an advanced state of irreversible decline in their capabilities. And this either causes them enduring physical or psychological suffering that's intolerable to them. And I'm not going to talk about what suffering is. You'll hear more about that. But it's not about what I think is intolerable to them or you think should be intolerable. It's about what the person feels is intolerable. And these things cannot be relieved under conditions that they would find acceptable. A request for MAiD must also be made voluntarily, and it must be an informed request. They must be informed of all means available to relieve their suffering. And this is a safeguard that we take very seriously. We want to make sure that people have been able to explore and access all the things that are available to them reasonably. And this can vary across the country. We know this. Equity is not always as easily attained as we would like it to be. So that's kind of the standard for anyone who's making a MAiD request. But there are also some additional things that need to happen. Each patient will require 2 assessments. One will be a primary assessment. The second assessment will be done by the prescriber. And the prescriber is the person who would obtain the medications and administer the medications that would cause the death. We have people who are in the track 1 group who have a death that is reasonably foreseeable. In recent years, previous years, there was a 10-day waiting period that has since been waived. And as we move along into the second track of patients, there are more safeguards. And in those people, they require an agreement between both assessors that their death is not reasonably foreseeable, and that they require an expert opinion as well. The expert could be one of the assessors, but sometimes we have to reach out to someone else. What's most important there is that there is a 90-day waiting period, and that period begins from the time of the first assessment starts and moves along. And sometimes assessments can take months. I mean, I've spent like 6 months on one assessment. So these do take some time. These safeguards are taken quite seriously and are the same across the country. Informed consent must be provided the day of the administration of medication, immediately before it is administered. The patient's in charge. They can withdraw anytime that they want. They can say, no, today is not the date. And waivers of final consent are also available, but only for people who have a reasonably foreseeable death, not for people who are in the track 2 category. People must have capacity to make this decision. And sometimes that's complex. I could say a whole lot more. That's a lot to squeeze into 8 minutes, but thank you. And I'm sure you'll have questions.
Okay, now that Laurie has talked about eligibility criteria, I have 6 minutes to talk about suffering in the context of MAiD and palliative care. And I am going to talk about palliative care as well, because I think it's difficult to talk about MAiD without also talking about the suffering that happens at end of life. So first of all, I want to talk about really in kind of broad categories, the 2 types of suffering that happen at end of life. And the one that people think about is certainly pain and the anticipation of pain. And in the recent report, the recent national report, that was about the 3rd most common reason why people would seek a MAiD death. And that would be pain or the anticipation of pain. But I think it's really important to note that we've come a long way in palliative care, and the actual situation where people have what we call a bad death and die in pain is actually quite rare. But what it is very challenging is when it happens, it leaves an incredible memory for people. I've done research in rural palliative care for a number of years, and it's interesting because I would go into a rural community and I would interview a number of people around palliative care in their community. And rarely would I hear about many, many deaths that had gone well. I would hear about the one or two deaths from multiple people in the community that had not gone well. And so we need to remember that it does leave an impression with people. But there's kind of another big, broad category of suffering that I think we all have to face at end of life. And that's what I would call existential suffering. And that's that suffering of relentless loss that actually occurs to people over time, often when they die of complex chronic illness over a period of time. And again, in the recent report, it was fully 86% of people said that one of the main areas of their suffering was their inability to do things that were meaningful to them anymore. And the second most common, at 83%, was the inability to do activities of daily living independently. So those are kind of the categories of suffering that we see at end of life. How does MAiD enter into that? Well, I think one of the things that MAiD allows for people is to set some boundaries around that suffering, right? It gives people some control over the timing at which they will end that suffering. And it's really interesting because this is kind of the fundamental tipping point where people either agree with MAiD or not. And it often relates back to how you think we should interact with suffering. Age-old human question, right? We've been debating it for eons. Is suffering something that we try to combat and extinguish at all costs? Or is suffering something that helps us to grow and transcend as people, or somewhere in between? So, but really that is the issue. And when it comes to criteria for suffering under the MAiD legislation, if, as Laurel mentioned, you're under track 1, which means your natural death is reasonably foreseeable, really you have to say that my suffering is enduring, it's intolerable, and it can't be relieved in a way that's acceptable to me. Now, if you would be a track 2 applicant, that's a little bit different. Then there's a sort of an added criteria that both the person who's making the assessment and the person who's applying have to agree that they have at least considered the things that might be available to them. And that piece of being available to them is important. They've considered that to relieve their suffering. But I think it's really important to remember that MAiD in and of itself, from our research, seems to have its own kind of unique suffering trajectory. As you can imagine, it's really challenging to plan at times the time and the circumstances of your death, to bring your family along with that process, and to wait over that time. So it's not that there aren't some unique things that go with that. I want to also share 3 points of wisdom from the many nurses and assessors and providers that we have interviewed across the country. And these are particularly for people who are actually considering MAiD or walking with someone who is. And one is they say, know your suffering story. Because if you request an assessment, one of the first things that they're going to ask you is for you to tell your story. Tell me the story of your illness. Tell me why you're applying for this today and not a month ago. And they're doing that not to challenge your story or to make a judgment of it, but to make sure that your decision is something that has been something that is in keeping with your values for a very long period of time. The other thing they've told us is that bring your loved ones along. A lot of people who live with illness over time, they become very stoic and they don't want to burden their family members and friends. They feel it tires them over time to hear the same story. But if you don't bring your loved ones along with the experience of suffering that you're having, then often they get taken by surprise. And so it is really important to talk about those things with your loved ones around what the effect is on you. The third thing they've told us is don't anticipate what your quality of life is going to be like as you travel your illness trajectory. Many of them have said to us, it's an incredibly humbling experience to walk with people. And what we learn is that quality of life is very elastic. Often what gets taken away, something else comes. And so I just want to finish too with the idea, coming back to palliative and end-of-life care, is I think we need to know death better. I think we need to talk about it better in our society. And I think we need to get away from some of the cultural and media stereotypes that have formed our impressions. It's interesting, I'm looking at a few palliative friends in the audience here tonight, and you know what? They're some of the most passionate nurses you'll find across Canada. They love their job and they never want to change. And there's a reason for that. And that's because end of life, whether it's with a natural death or a MAiD death, can be a mysterious, healing, amazing experience. I'm going to turn it over now.
Thanks to all of you for being here tonight, and thank you, Sally, for the introductions. My clinical and research experiences with MAiD have shed light on multiple ethical dimensions associated with and the potential impact that it has on patients, their family members, and healthcare providers. And I'll share a few here tonight. The first one is I'm going to touch on capacity to consent, or that requirement. So one of the key requirements to access MAiD, as was mentioned before, is that the person has that capacity to make decisions and request and receive MAiD. And so our findings have revealed that patients often withhold treatments or medications that they believe would affect this decision-making capacity, so by withholding this, they're trying to maintain that capacity in order to be able to access MAiD. And then often some individuals resort to requesting MAiD early in the trajectory of illness to maintain this capacity as well. And this can be often distressing. But on the flip side, our research also highlights that patients tend to request MAiD relatively late in the course of their illness, which can then unfortunately also lead to ineligibility because of capacity loss. And so this might be because of the lack of awareness about one's health status and prognosis. And this could lead to postponement of making treatment decisions and as well as making requests for MAiD. And so the discussions surrounding death and dying, these can be challenging to have. So in the Western society, the focus is often on finding cures and or to prolong life. This is the focus often. And so discussions around death and dying tend to be evaded because of social cultural stigma surrounding death and dying. And so as patients, it is important to have candid conversations about one's diagnosis and possible treatment options and what prognosis can look like with healthcare providers. So asking questions to them, finding out about this health. And so when you have that, you are empowered with that information, you can make decisions about end of life and or just decisions about the care that you want that aligns best with your values and wishes. And so sometimes the healthcare providers sort of don't tell you about these or have these conversations about prognosis and or treatment decisions because they want to maintain a sense of hope. And so it's important to sort of ask these questions so we're informed. But it's also equally important to share one's values and wishes, as was mentioned earlier, with your loved ones and with healthcare providers so they are aware of what your treatment choices are and what you would like your end of life to look like. Because when you're unaware, they can be caught off guard with your request for MAiD, and that can often then lead to delays in the MAiD assessment and provision processes. It is also important to reevaluate these values and wishes as your life progresses and your disease progresses, because your values and wishes can change. You may change your mind about something that you had decided earlier on. And it's always important to reconnect with family members and talk about these changes in values and wishes. Having these conversations not only, it does ease, this perceptions about urgent requests for MAiD, but also allows family members and healthcare providers to support you through your choices. but it also minimizes burdens that family members might face once you've lost capacity and you cannot make your own decisions. They're not empowered to help you through your end of life, even when you cannot make your decisions or when you cannot access MAiD. Secondly, I want to talk about a little bit about palliative care. I know it was talked about earlier, but there are some misconceptions surrounding MAiD and palliative care, and that is that it can be mutually exclusive, but it really isn't. Our research shows that the best outcomes are maintained, or the best outcomes come from seamless access to both palliative care and MAiD. And so, unfortunately, though, there's disparities in access to healthcare, including services such as mental health resources and other supportive therapies. And this can not just across Canada, but even here in BC. And in the absence of these services, it can be hard or challenging for healthcare providers to come to terms with or to be involved in MAiD requests, especially for patients whose death is not reasonably foreseeable. And that brings me to the next point, and that's vulnerabilities that healthcare providers experience. Often healthcare providers describe their role in MAiD as rewarding and meaningful, but it's essential to acknowledge that these roles come with substantial challenges. Often people who provide MAiD are seen as being in a place of power or having power over people, but that outlook we have on patient or on healthcare providers often overshadows the vulnerabilities or the moral distress that they themselves experience being involved in this work. And so various factors, including lack of professional or psychological support, especially for healthcare practitioners who work in isolation or in remote locations, and then there's also risk for, they are worried about risk of professional or legal ramifications of being involved in MAiD. And then of course there are media reports on some of these MAiD cases that also worries them. So there are many issues that can cause moral challenges to these healthcare providers. Recent changes in the legislation have also increased workload for healthcare providers and resource demands. And so there may be delays in reaching the patients who've requested MAiD and providing MAiD as well. And so members of the MAiD teams occasionally encounter challenges from family members, particularly when these delays lead to capacity loss and related ineligibility for MAiD. And so unrealistic expectations of how MAiD provisions should occur may also are expected or were expected to surge with the changes in the legislation and the expansion of MAiD to persons whose death is not reasonably foreseeable. While access to MAiD has broadened to include those whose death is not reasonably foreseeable, there remains a shortage of healthcare providers who are willing to assess and provide MAiD for persons whose death is not reasonably foreseeable. And I'll stop there and hand over to the next person.
Thank you, everyone. I'm delighted to be here with you. And as the visitor to Kelowna from Saskatoon, I work at the University of Regina at the Saskatoon campus. So as a visitor here, I thank my panelists for their welcome and all the helpers and volunteers, as well as all the people in the crowd. I really appreciate all the smiles that I'm seeing out there tonight. So thank you for welcoming me to your community. I'm Janine. I'm a proud registered nurse. I worked in long-term care up until 2022, 2020, when the pandemic started. Then my academic job kind of took a life of its own and I couldn't quite keep up in both worlds. My entry point into studying MAiD and learning about MAiD really came from the bedside. We were working nights one night and I was flipping through the charts, making sure there was enough paper for the next day for the day shifts, and you see that so-and-so has requested a MAiD assessment. I was like, I heard that this was legal, but I have no clue how it happens where I work. I have no clue about what happens if people want it or don't want it, or the nurses don't want to participate, no idea. And so it started quite a lively conversation in the lunchroom that night about, well, I could never, or this is the best thing ever. And it really kind of opened up this whole world of It's a legal practice. How are we doing it and how are we doing it well? So that's my entry point. I will build a little bit off of what my panelists have shared before in terms of there is a growing number of individuals accessing an assisted death. And as that number of individuals accessing an assisted death increases, the number of providers, which the law says can be nurse practitioners or physicians, is not sustaining that number of patients. So the work that I did in Saskatchewan was to talk to physicians and nurse practitioners about what is making you hesitant to participate in the practice of having conversations about MAiD, assessing patients for MAiD, prescribing for MAiD, and or providing MAiD. Through that work, before we get into the work, one of the pieces that we talked about the law, and the law is very clear in many things, eligibility criteria, safeguards, a number of pieces. Another piece that is very clear in the law is that it said not any one practitioner, nurse practitioner, physician, or otherwise, is compelled to participate in MAiD. So the freedom of conscience and religion stands firm, and there is still the ability to access an assisted death and or end of life choices in Canada. So finding that line is always going to be important. So the law does not compel individuals to participate. There is other pieces of the law and case law and best practices and regulars policy statements that define that line of when participation can be pulled back. So an effective referral is often still needed. If I can't journey with that patient any further, an effective referral is still important. So when I talk to these nurse practitioners and physicians about what made them hesitant or reticent to participate, probably not surprising, some of those factors that influenced that non-participation came from within, right? It didn't fit with my spiritual beliefs. I don't know how I would account for myself when I meet the pearly gates, when I'm at the pearly gates. I don't know if I'm ready to accept that responsibility of ending a life. I'm not comfortable with death. I get it when I'm a doctor or a nurse practitioner. I might encounter death, but to sign up and do that full time, I'm not sure, right? So there's kind of some of these factors. The other piece that felt that kind of internal stuff is I just don't know how this fits with my professional ethos. Like I know how to help people die well. I know how to maybe work in the palliative care world, but I don't know how to affect someone's death. I don't know how to do that. And I don't know if that fits with what I signed up for when I signed up to be a nurse 25 years ago or a doctor 25 years ago. Others were concerned, like Dr. Variath mentioned about the emotional labor. That's what I termed it, the emotional labor of the work. They saw the work that their colleagues were doing and that grief, emotionally laden, somewhat isolating, grief-intensive environment. And it was like, yeah, I'm not sure. Not sure. There's already a lot of moral distress in healthcare these days, right? So I don't know if I want to go there. I see what it's doing to my colleagues. And then in that same vein, but kind of thinking about future, is I don't know what I would do in the long term in terms of like PTSD. If I'm identified as a MAiD assessor or provider, am I going to be ostracized by my peers? Am I going to be ostracized by the people at the clinic, the healthcare staff at the clinic? If they see me as an assessor or provider, are they going to respect me less? I came from Saskatchewan, so I talked to some rural people, right? And they're like, I don't just nurse that patient, I nurse or physician take care of that whole family. So how are the other people in the family going to see me? How is that going to affect my relationship with the other patients in the clinic? So there's all these kind of factors. Some of the other interesting factors that influence the ability of the physician or nurse practitioner to step into that role were also external to them. The system. I don't know what the best practice is. This just became legal. Like we have best practices for cardiology. We've got best practices for diabetic care. We've got best practice. There's no roadmap here. I don't even know what I'm doing. That makes me uncomfortable. And then they got uncomfortable because of the risk. We talked about that too. Legal risk, professional risk, getting called up to the board, physical concern for their physical safety. physical concern about life made difficult at the clinic by their colleagues, time constraints. I only have 10 minutes to see a patient in the clinic. If I go out and do a MAiD assessment or provision, rightfully so, that might take me 4 hours. And if I'm practicing in small town X, that might be 30 patients I'm not going to be able to see that afternoon. So how do I juggle all of these competing demands on my time? And if I'm going to step into that world of assessing and providing for MAiD, how do I do it well? So just some of the food for thought about from the practitioner end when we think about MAiD, and that really there is conscientious objection for sure to MAiD, and that has to be respected by law and to protect the moral integrity of our healthcare practitioners. But how do we also affect a system so that some of those other barriers potentially can be mitigated so that they feel safe to practice? So thank you.
Hi, everyone. I am speaking to you from my experience working in Vancouver and within the health authority. But from what I hear from people within interior health, it's a very similar experience. So I'm hoping that they'll be able to transfer. My job here tonight is to talk to you about the family perspective of what people supporting their loved one through the assisted death, what that's like for them, and just some tips about some things to keep in mind. We're going to talk about some myths that I think are pretty common, how we engage with families and what that looks like, or the intention to do so, a little bit about privacy, and then last about hope and grief. So the first one I want to say is there's lots and lots of myths out there about MAiD, which I'm sure that you're aware of. And I would encourage you to call your MAiD Care Coordination Center if you have any questions. They're the people that have the information. You probably read something online that may not be true. So if it's keeping you up at night and you want to understand, or your loved one or yourself is already connected to a MAiD practitioner, call them, and they're the best people to help you understand what's going on. The next one is about timelines. With the upcoming legislation change allowing people with a sole diagnosis of a mental disorder to apply for MAiD, there's lots of people talking about my 23-year-old son is going to come to emerge and then he's going to have MAiD the next day. As Lori has described, that's not what's going to happen. So we want to make sure that we're understanding it and identifying, are we a track 2 person? Is it somebody who has a natural death that's reasonably foreseeable? Or is it someone that doesn't have a natural death that's reasonably foreseeable, and not conflate those 2 timelines? So as Lori mentioned, there's the 90-day assessment period. And so that takes a long time to go through that assessment. And our assessors and providers take that time to make sure that the person understands the things that they have at their disposal to address their suffering. And so sometimes it can take longer than 90 days. Sometimes it can be a year. But that's the time we want to take to make sure that this is the right choice for that person. The next thing I'll talk about is family engagement. We're very aware that every family comes into this system with their own methods of having conversations about end of life, their own way of making decisions, and it's really important that you help us understand what that looks like for you. So if you have a loved one going through this process, please take the time to say, this isn't how this works in my family, or thank you so much for supporting that. We need you to help us come into your family, and we want to be able to communicate effectively with you. If you find it uncomfortable, I would encourage you just to speak up and say, this is what we need. The second bit is next about privacy. There's a lot of people that are concerned that their loved one's going to go through this process without telling them. And that may happen, and that does happen. But the reason we're doing that is we need to maintain confidentiality rules. And so if we have a patient that says to us, I don't want to tell my family, I want to assure everybody we don't take that lightly. We never say, okay, no problem. You don't have to tell your family. We try to understand what that looks like for you, why is that person saying that thing, and that's not a decision we take lightly. If we feel like we need information from the family to help us make a determination about MAiD, our job is to tell the person, if you won't let me talk to your family, then I can't find you eligible. So that's something that I think is another big myth. If we need information from you, we're going to come and get it. The second last thing I'll talk about is hope. A lot of people think, like someone already mentioned, if I talk to my family about MAiD, then they're gonna stop supporting me in my effort to address my chronic pain, or they may stop supporting me in my effort to address another healthcare concern. So we try to bring people together to say, we've also found that MAiD helps people with hope, because they know that there's a potential way for them to relieve their suffering. So we know that people who have requested MAiD and they're at the end of life, it can sometimes extend the quality of life now that they've been determined eligible for MAiD. One last bit. And then the one other part is that we find that MAiD really changes what it looks like in the last couple of months of a family if they know that an assisted death is happening. They may, instead of choosing to do their taxes, they may decide to go for a walk with their loved one. They may decide to have that difficult conversation with their sister where they think that they have a rift, because they know that an assisted death is taking place and they may not have the chance to do that afterwards. So MAiD is difficult. We hear and understand that. As you heard, it's difficult from the family's perspective, from the patient's perspective, and from the healthcare provider's perspective. What we're hoping is that you can be part of the team and part of the family. And if you're having difficulty, it's important that you tell us, because we may be having difficulty too. So one, I'm really grateful that MAiD has opened up the ability to talk about end of life and change those conversations. And I'm hoping that that will continue as we move forward. Thanks.
You've had a barrage of information from people who are clearly passionate about their work and committed to their work and have a lot more ideas than we gave them time to share. I'm just going to give you a minute of instruction so you can know what will happen, and then we'll take a 10-minute break together before we come back into question and answers. So, to remind you, you have information on or in your bags about the Slido. If you're somebody on a cell phone and you want to join in that way, do that. You'll have that, those online will have that information as well. And if you are interested in doing that, you'll find paper and pencils on which you can write down your questions. If you know which one you want the question to go to, feel free to add that in. And our wonderful little helpers will take the pieces of paper and get them into the computer magically so they'll come up on my screen. We're fairly sure with this many people in the room that there will be a million questions and we won't be able to get to them all, but our helpers will try and ensure we get to a range of the questions. And if there are 3 or 4 that are alike, then they may just pull one so we're not just on one topic, just so you know how that will work. And if we can't get to all of your questions, there will be information. We will be leaving you with information as to who you can contact and where else you can find out more reliable information when we leave. When we have to say goodnight, we'll hang around for a little while if there are any unanswered questions. So let's take our 10-minute break, have some table talk, see who's here, and have a little chat, and we'll regroup. It is now 7:15, and we will regroup at 7:25. kind of ashamed to interrupt this lively conversation in the room. Some of you clearly have found the Slido and feel free to continue to add questions into that. If you found it and you're not adding questions, you can vote on other people's questions if you really want them answered, and they'll rise up to the top. And if you've written something down and nobody's picked it up yet, just wave at one of our helpers and they'll come and get that. Well, thank you very much. We do have some very good questions here. And I'm going to start with a question that was raised as to whether MAiD is assisted suicide. And I think that's an important clarification to have first. In our society, in our medical care system, we think of suicide as a desperate act and often as an impulsive decision that may come and go. It's considered in the spectrum of a mental health issue because of that. And that's very different than a reasoned decision that one wants to make an autonomous choice about the end of life. And so we don't use in Canada the language of assisted suicide. We distinguish that impulsive desire to die that could happen when you've had a loss or a transition or something like that, from the more reasoned choice that we're talking about. Now, the mechanism by Canadian law of how the death would occur can be in two ways. Most of the people in Canada who have a medically assisted death have it by injection by a physician or nurse practitioner who's been involved in the assessment and in the plan with you. There's a small percentage, because there is provision in the law for a prescription that you can take yourself. When people hear about the implications of those choices and the confidence in how it will work and how they will be managed, the majority of people have been choosing the injection that involves a physician or nurse practitioner. So that's the context in Canadian law, and I just wanted to be sure that we all knew what we were talking about here. So I'll go to the first question on Slido. It's, can someone who has Alzheimer's, whose disease is progressing, but still there, and knows of the suffering that lies ahead, can that person request the right to die? It's a great question. I'm going to turn to Carolyn first.
Thank you, Sally, and thank you to the person who asked the question. Can you all hear me okay? Perfect. So there was a misconception that if someone has Alzheimer's, then they may not be eligible for MAiD. If a person has been diagnosed with Alzheimer's, they can request MAiD, because being diagnosed with Alzheimer's does not mean that they don't have decision-making capacity or they lose decision-making capacity with that diagnosis. So a person who has Alzheimer's can make a request for MAiD, but they have to meet all other eligibility criteria and safeguards set forward in order to be found eligible. Now, if a person with Alzheimer's has been found eligible, and the healthcare providers who's done the two clinicians who's done independent evaluations or assessments of eligibility find the person eligible for MAiD, and if there's concerns that this person might lose capacity after being found eligible, they can enter into an agreement or waiver of final consent, which allows them to access MAiD after being found eligible, even if they lose capacity to consent at the time of provision. And that is where we stand right now. So the person cannot ask for MAiD. It cannot be an advanced request for MAiD or advanced request for MAiD. The person has to have capacity to come forward and ask for MAiD. And if they meet all other eligibility criteria, they can go forward and receive MAiD. Is there anything else? Is anything else missed, Lori?
Just as a point of clarification, the waiver is only used in track 1. So this person would also have to have a death that is reasonably foreseeable. So one would imagine that they don't have just Alzheimer's disease, that there may be other underlying conditions causing suffering and such. We're not at a place in Canada yet where we can make MAiD as part of an advance directive. So this is where it gets very complex. And this is really an excellent question because it demonstrates how complex assessment can be sometimes. You know, often a request will come in and you will see that it is clearly going to take a lot of energy and time to tease out the eligibility pieces. Have we met all the safeguards, etc. So just because a person has cognitive decline, such as Alzheimer's disease, does not make them ineligible, but it may be a more complicated path that we travel. And I hope that answers that.
Okay, next question. Can you explain more about the track 1 and track 2 processes? Maybe I'll ask Laurel.
Sure. So first of all, anybody can apply for MAiD, so I could apply, and I wouldn't be determined eligible, but I could apply. So when we first get the request in, majority of the work that happens within British Columbia happens through a MAiD care coordination service. That's met with social workers or nurses that initially look at that first request, unless you give it to your GP. So there's lots of ways. Then those people, they look at it and they determine, okay, who does this go to now? So then they send it out to an assessor or provider, or maybe your GP is connected with you and then they can assess you. When they're doing an assessment, they go through the eligibility criteria, and the main thing they have to determine is, do you have a natural death that's reasonably foreseeable or not? This is not necessarily something that I would say is black and white. There's lots of different opinions about what is considered reasonably foreseeable, and we've written things within clinical guidelines to help practitioners with that, but that is still under a lot of debate. So you may hear of someone over here who has the same condition as this person was track 1, this person was track 2. So for track 1, you need to have 2 assessors determine you eligible. And in this track, there is no wait time. You don't need to wait. You used to have the 10-day wait, now there is no longer a wait. So then if you're determined eligible, then it's up to the person who has applied for MAiD to determine if and when they want their death. So that can happen quite quickly. Majority of people, it happens within 21 days is our mean of when people have an assisted death, with a long tail out. Some people have requested MAiD 2 years ago and they still haven't proceeded with an assisted death. One last bit I'll say is that half of the people who apply for MAiD within our program proceed to an assisted death. So just because someone applied, that does not mean that they will have one. A lot of our people withdraw their request, or they have a natural death without asking or requesting MAiD. They move out of the health authority, etc. Then for track 2, if they've been determined that they don't have a natural death that's reasonably foreseeable, that's a much more involved process. That's serial assessments with our MAiD providers and MAiD assessors, which can lead to a determination of ineligibility, which we try to, if we know that that's going to happen, we try to connect that person with other supports to make sure that when they hear that determination, that they have supports with them. Lori, anything to add apart from 1,000? Because it's very complex.
No, I think you've captured it well. I would just add to that track 2, when it came on through the changes in legislation for patients with death that was not reasonably foreseeable, it did make things more gray for me personally and for many of my colleagues. And we had to kind of take a step back and say, okay, how are we going to approach this? Yes, it is more work, it's more complex, but it also meets the needs of many people who are suffering in ways that are absolutely intolerable to them. So I'm thankful that we have it, but it has required more thoughtful, careful review. In our health authority and Interior Health, every track 2 case is audited, every single one of them. And that's just fantastic because we learn so much from those audits. And we share that information with all the assessors and providers. So this is this was a grassroots thing, and every year, month, week that goes by, we are learning from what we have done.
Perhaps useful to be aware that when this legislation first came in Canada, the assumption was that it would be something available to people whose death was soon to come. And that was the group that the original legislation was intended toward. Quickly, we realized that death is, as you know, not predictable. That there are people that you feel that look like they've got a week or two left to live, and a couple of years later they're still living. There are others who you expect to live for a long time and they don't. So it really is a very, very unclear parameter. And so there was a lot of pressure among those for whom the doctor wouldn't say, this person's likely to die within 2 weeks, who just to say, I want to be considered as well. So with pressure from the public and the realization in the healthcare sector of how complicated this is, the legislation was changed in 2021. And there has not been a long time yet for this second legislation in track 2. So you're hearing this group talk about the practices as they're evolving, and they will continue to evolve with the conversations by patients and the public and providers across Canada. So it's not fixed at this point, and if they're not giving you fixed answers, it's because often these things are evolving. I'm going to move to the next question. I see there's a MAiD. This is a question by Sandy. I see there's a MAiD coordinator for Vancouver Coastal Health. Are there similar people throughout the health authorities in this province? And can the public use them as a resource? Or how best do we link with MAiD? Barb? Oh, you could answer it, but I was thinking Barb.
Sure.
Pass it to Barb after.
I'm grateful for the Minister of Health in 2016 requesting that every health authority needs to have a number and an email to address questions, because at that time MAiD was controversial. So because he required that, that meant that people had to be there to answer the phone, which meant that MAiD care coordination services were created in every health authority. We have become a very close-knit group. Yes, absolutely. Anybody from the public can call them and ask them any question. And they're there for you. We're there for you, and that's we're happy to talk to your brother in Taiwan if that's what you need. I'll leave it there.
One piece I would like to add to that, I think, when the first MAiD law came into being, it was basically an amendment to the Criminal Code of Canada, right? So whereas before someone could not affect someone's death without getting charged with homicide, now there was provision saying under certain circumstances you can affect someone's death and it be part of a well thought out medical team approach. It was a federal law that changed. Provincial provinces and territories have the responsibility for delivering healthcare. So it'll look different in each province. And I know there's a number of people online. So one of the really interesting pieces, but also challenging pieces, again, is when we start thinking about good data and good best practice development to think from province to province, the model of delivery in Saskatchewan is very different than the model of delivery in BC, which is very different than the model of delivery in the Yukon or Ontario or the Northwest Territories or Nova Scotia. So it's very interesting. So yeah, in BC there's a wonderful setup. Saskatchewan has a slightly different setup. I would think for people who are joining online or for people who have family out of province, connect with your GPs, connect with your government health services online site. You should be able to find information about how to access care. If not, the Government of Canada website also has information about how you can link in the various provinces and territories across Canada.
Good. I'll come to a question to Barb in a moment. I just wanted to interject by saying, as you're writing down your questions, unfortunately, we can't answer really specific questions about your individual eligibility. We won't take those kinds of questions online. If you're here in the room, after the session closes, you could perhaps talk to one of the panelists to ask for where to get information if you do have a specific question with regard to yourself, or we can make sure that you know how to access a MAiD coordinator. As Janine said, everywhere in the country, there needs to be very clear information so that everyone in the public who has a concern or a question knows how to reach out and how to get to the right people. In British Columbia, we do have a very good system evolved. For some strange reason, the public of British Columbia seems to have taken to medical assistance in dying pretty enthusiastically, and we do have the highest rate of provinces in the country, with the exception of Quebec, which is a little just about at the same level. So we have had to set up pretty robust systems, and I just assure you we'll make sure that you have access to those if that's what you came for. The next question for Barb. Is mental or psychological pain considered a form of suffering for MAiD?
Oh, that's such a good question. Yeah, and I need to differentiate because, as you know, in March 2024, the embargo will be lifted for those whose mental illness is their sole underlying medical condition. But I think it's pretty safe to say that you can't separate necessarily physical and psychological suffering. I was interviewing a person the other day and she said, yep, a patient said to me, you know what, it's like making a cake. They said, once you put the ingredients in, you can never separate them out again. And that very much is the case with suffering, right? Is that physical pain can lead to mental pain, and once it's together, you can't separate them out again.
And another reason that's very important is just that again, reminder that withholding your pain medication so that you'll be able to demonstrate enough suffering is not a good idea. You know, yeah, you hear too many stories about people afraid they will look too well or too cognitively intact, and it's quite important that we all feel so strongly that everything we can do in our communities and our healthcare system to alleviate suffering is still a good idea, and that should not preclude someone having conversations. So,
just want to add one anecdote. I'll put on my associate dean nurse educator hat for a minute, right? First year students, we tell students, patient's pain is what the patient says it is, right? What's your pain on a scale of 1 to 10, right? Pain is what the patient says it is. Suffering is much the same.
And it's very different between individuals. This can be hard in families as well. When somebody looks well and they're up and about and socializing and looking like they're comfortable, but deep inside they may be deeply existentially suffering. So as you can imagine, these are hard conversations in families, and they're hard conversations with healthcare professionals. The next question, I think, is probably for Lori. If I was unable to verbalize my request for MAiD, but I'd made my wishes clear in my advanced care directives, could my substitute decision maker request MAiD on my behalf? For example, if I had a stroke and could not express my wish.
That's a great question. And the answer really is simple. You can have substitute decision makers for many things in life, but not for MAiD. MAiD requests must be made by yourself, and it must be uncoerced, and it's required in writing, although there are some ways around that too. But yeah, no, I wish that one day we might get there, but you could see and you can imagine right now all the complications that would arise with that. So this is one time where it's, you know, pretty much no.
At least for now.
At least for now. And, you know, the future for advanced directives will, you know, set us up for some possibility of this, but I think, you know, there's a lot of work to be done in that area still, but I'm hopeful.
At the same time, we would never want to discourage any of you from having these advanced conversations with your friends and family. There's no question that the decisions that are made around the end of life for people are much easier if everyone understands what your wishes and values would be. And you can't always know what that scenario will look like when the time comes, such as, you know, avoiding unnecessary aggressive treatment or something like that.
And just a little clarification, or something I should clarify, just because someone is nonverbal does not mean that they can't make a request for MAiD. There are many ways around that, but as the assessor, I still have to feel absolutely comfortable that they understand the information I'm giving them and that they're communicating back to me in a way. So there's many tricks in the trade for us to do that. So yeah, rest assured, if someone is nonverbal and wants to make a request for MAiD, that can still happen.
Okay, next question. And this is perhaps Laurel, not sure. Can any doctor or nurse practitioner be a MAiD assessor and or prescriber? And if so, do they receive additional training for their roles?
Right now, based on the college requirements, any physician can act as an assessor, and they can also act as a provider. Nurse practitioners require additional education. The way that MAiD was created within BC because of the health authority's requirement to have a care coordination service, what that meant is that a lot of GPs said, okay, well, if you're going to do it, I'm not going to do it. So then the care coordination centers all decided that we need to have physicians and NPs. Then that meant that we created rules around what kind of education we would like them to have in order to provide MAiD within our region. So within British Columbia, we have a pretty robust system of making sure that those that are prescribing and providing MAiD have education. Yes, there's a new curriculum that came out from the Canadian Association of MAiD Assessors and Providers, hoping to harmonize and standardize MAiD education across the country. And so unfortunately, members of the public can't do that, but it's free for the next 3 years for physicians and NPs. And so we're hoping that that will support people having equal understanding and education about assessing and providing.
In general, there's great enthusiasm among those who are doing that assessment and provision work for as much education as possible, to really to listen to one another, to hear the complexities, to truly understand the legislative and clinical context. It's a community that's really hungry to try and do this right and well and properly and morally and ethically and in a way that's humane and clinically excellent.
Just want to add one thing to that is that part of being a MAiD assessor and prescriber requires privileging. So there's a privileging process for that we undergo, and that's the bit where medical directors and such that are in charge of these things make sure that we're keeping up with the most current information. And how did I do that this year? How many case review rounds did I attend? And that's in interior health, that's an expectation that we attend these case review rounds as a way of extending our knowledge, stretching our brain, hearing about the challenging cases. And I'm ever so grateful for the CanMap education program modules. They're very solid. They're going to be a good benchmark for all things moving forward, and will hopefully, as Laurel said, harmonize our learning.
I think the next question is also a barbed one, but others may want to weigh in on this. It used to be that as a registered nurse, we were not even supposed to speak of MAiD. As a community palliative nurse, we get asked about the program all the time. Are there parameters around what information we can share or not share?
Yeah, this is such a good question. We've been doing research with nurses since 2018, I think 2017, actually, even right after the legislation. And one of the first things we did was reviewed all the nursing college regulations in terms of what nurses were allowed to do and what they weren't allowed to do. And it really varied across the country. And in some provinces and territories, nurses were told quite explicitly that they were not allowed to introduce the conversation at all unless patients actually use the terms euthanasia or medical assistance in dying. That has changed a lot over the years. And again, nurses still need to check their provincial regulations, but more and more nurses are accepting that it's a really, really important part of care planning, advanced care planning. And there's a compelling reason for that. And you will rarely see this in the media. And it's because the times of transitions that people go through, whether that's a transition into long-term care, whether it's a transition in their illness, where all of a sudden they're much sicker, that's generally not the time that people should be making the decision for MAiD, because it's a time of duress, right? So a decision like this is really a sobering one, and it needs to be in keeping with values that you've held for most of your life. That's what our assessors and providers will tell us. And so what we're beginning to understand is that if it's introduced to people at times of less vulnerability, times when they're feeling less stress, they can make their wishes known. And they can say, no, that's not for me, don't bring it up again. Or they can say, you know, that's actually something I might consider under the right circumstances. And so what we're really beginning to see is that changing. CAMAP has come out in support of that being an important part of advanced care planning. Nurse practitioners certainly do it across the country as part of their role. Registered nurses still need to kind of abide by their guidelines. But just to give you some background on that, in the criminal code, there still is a little clause that you can't counsel to commit suicide. And that's really about, you know, in the language, that's kind of like, I should draw on Laurel for this, but it's language like inciting people or encouraging people. It's like strong recommendation that this is what you should be doing. And unfortunately, that kind of got misconstrued as giving information, or even, you know, if somebody alludes to the fact, because a lot of people won't use MAiD, they won't actually use the term. They'll introduce it in kind of veiled language because they're not even sure how the healthcare provider will respond to them. Will they reject them? Will they be horrified that they brought it up? So they'll kind of talk around it a bit. And it actually takes a really skilled nurse to try and figure out what that conversation is about.
We've been trying to use the findings of our research to work with nurses to help them find appropriate ways to have those conversations in appropriate moments. But it's nurses who don't necessarily think of themselves as palliative care or working at end of life. People who work in hospitals and communities and long-term care facilities and any place where they may encounter people. And if they don't learn how to create those openings and conversations, what we know is the people who will raise it themselves are people with privilege and education and who are confident in society. And it's the still silent voices that won't raise it, that are too shy to raise it. So it becomes a serious equity issue. And so for nurses, it's really very important that we learn how to create the space that people who are hoping for that conversation will have it. And it may come up in a very veiled way in the middle of the night saying, how long does this have to go on? Or is there anything you can do? And every nurse who's worked with patients in the middle of the night will have heard those questions. So it's a real change for us, instead of saying you're prohibited from that conversation, to think about how we can help people into those conversations.
Oh yeah, I just want to add to that. And some of us may still not be comfortable in having that conversation, but it's really important to know who to contact, even if you have an inkling of doubt that this is what the patient wants to talk about, but you're not sure. If you're not comfortable, then it's just equally important to have someone else come and have that conversation with the patient.
Absolutely. Okay, next question. This is from Nicole. How are we protecting patients' information, like MAiD applications, as they navigate the healthcare system, so to avoid harmful stigmas while they're still seeking care or treatment? Lori, would this be for you?
I can take
Laurel.
it. I'll take it. It's a very good question. We often have patients say, please don't tell my GP because I'm afraid that they're going to stop providing me care because they knew they don't like MAiD. We're navigating this very gently, I'll say, within the health authority, and we're keeping patients' MAiD request close to our chest. We recognize that there's a stigma still about MAiD, and we recognize that we need to be careful. We also have a duty to document, and so we do need to make sure that we're abiding by our college regulation and documenting appropriately. We've had patients that we've said, because we need to document, this is going to go into some kind of record. Those patients then need to make a choice. If it's too big of a deal for them to have their care provider understand and become aware of that, then they can make a choice not to proceed. Our aim is to make sure that throughout the entire process, we're providing informed consent, and then the patient can tell us at any point if that's too great of a risk for them.
While Laurel is located in Vancouver Coastal Health, she's in very close contact with all of the health authority MAiD coordinators in the province. So this is a community of people who are continuing to stay in close contact with one another and ensure all British Columbians have access to that same thinking. Okay, next question. Is there any team or healthcare sector that looks at equitable access to treatments, such as providers can apply for psilocybin treatment through the SAP for end-of-life anxiety, but not many people know about this emerging treatment?
Well, I have a lot to say about equity, but that could be another evening event. Yeah, I mean, in a perfect world, we'd all be able to have access to everything that we needed. There is a program, of course, where people can access psychedelic medication for certain issues through Health Canada. I am not an expert on those things, but I can say that often things when they're new, there's a lot of barriers and restrictions around things that are new until we're absolutely certain that our research supports the reasons that we would use a particular treatment. So psychedelic medication to deal with end-of-life suffering, existential suffering, or PTSD, or any number of mental health disorders is just on emerging research. Yeah, you're right. Not many people would know that this is accessible through Health Canada. I'm sure there is many forms involved with getting access to it. But there'll be many things like that when they're new. And as the researchers, and I know there are many research studies going on right now in this area, as that evidence begins to build, then it nudges the things more forward so that the barriers can be dropped and it can be more equitable access. There is a clinic in your community of Kelowna that does ketamine, psilocybin assisted therapy, but this is also not equitable because it's costly, so it's not accessible to everybody. But again, it's new, and hopefully, you know, they will have conversations with governments and legislators that will see some of this, these treatments, new emerging treatments, be covered. We can say that about any new drug that comes on the market. So this is the way of the world. Hope that helps answer your question.
I'm now going to combine the next two
Sally,
questions.
can I just add something to that a little bit? Can I just add a piece? In the research that I did with nurse practitioners and physicians, they too were concerned about system inequities and the access to MAiD when other services were already inequitable. I'll never forget one of the participants in my project. They said, I'm not saying I would never do this. I'm just saying, can we do everything else really well first and then we can look at this? You know, so I think there are system inequities are recognized and they are there, and it is a piece that impacts patients, families, and also I think the healthcare providers as well.
So these next two questions I'm going to combine, and I'm thinking that Barb and Lori and Laurel, they all want to weigh in on this one. The first question is a MAiD death painful? What actually happens? And the second, which I think is related, can any of the panelists share a positive MAiD death experience? What did it look like for the patient? And so I'd invite you to tell a story or two and to try and answer that question. Laurel, Lori, and Barb, in that order.
So the medication that they use is the same medication that we use when people are going for surgery. So if you have had a surgery and then you've woken up after that surgery, you can ask yourself, was that painful? And that's what the people who are, that's the medication that they receive. They receive those medications in much higher doses, but that's what we can liken it to. I've been to many, many MAiD deaths, and they're all different. And they're all different, not because of what happened with the MAiD itself, but they're different because of the people that was having the person that was having the assisted death and the family that was around them. Some of them are absolutely beautiful because of the experience that was going on with that family, and some of them were really hard because of the experience with that family. But absolutely, I've had many multiple wonderful experiences. And my overriding thing that I find in common is the person that's having the assisted death is very ready to go. And everybody else around them are the ones that are obviously having more difficulty because they're going to be left behind. Lori, what would you like to add?
It is not painful. It is the most peaceful death that I can imagine. And I've seen a lot of not peaceful death and deaths that were, really a hardship for those at the bedside and for the patient. But I'll just tell you a story, a short one. I'll keep it short because it's very true. Every experience is different because everybody is different and they have different levels of support. But I remember one particular woman who was quite elderly. She had a number of morbidities, and the combined effect of them had just made her quite frail. And she really wanted to have MAiD. She was assessed. We got all the ticky boxes done, and we were setting a date. And her daughter said, "Oh, can we wait till Saturday because Bob is going to be home on Saturday, and I know he really wants to be here." So we were going to wait, but I got a phone call at 7 o'clock in the morning, and she said, "Can you come today? Mom just can't wait." And I said, "Sure, I'll make it happen." So I, made it happen. And I arrived to a very small little house because she lived in sort of an assisted living facility. And I had a hard time finding a place to park. And I thought, what are all these cars doing here? And me and the RN walked up to the doorway, and I'm going, oh my God, there's a lot of people here. And we walked in, and the place was just filled with family. Like, she had a huge extended family. I'm sure there was 35 people in this little tiny space. And she was in the center, and they were all standing around. They were all singing her favorite songs to her. And I actually had to get everyone to leave for a little bit because we were having a little trouble with getting our IVs established, and it was hard with an audience. And everyone went outside and sat in sunshine, and then came back in and started singing again. And I don't cry often at a MAiD, but I was blubbering by the time that we were finished, and it was just the best experience for every single person in the room. I just can't. I still get goosebumps talking about it.
So I want to share a story of how I got into MAiD related research. My background, as I don't know if I mentioned this earlier, but I've worked in critical care most of my life in ICUs, and that's an important place where people can be provided life-saving treatments. But often, as I've mentioned earlier, there are patients who don't have enough information about their prognosis and/or their disease trajectory, and they end up in ICU where they may have benefited from other supportive therapies. And the number of patient deaths that I've been a part of that were traumatizing for the family members, horrible for the patient and for the staff involved, were far too many. And that is really something that struck me, and I am supposed to be helping people, and I felt that in those situations I wasn't helping the patient or the families or myself. And so I really looked for an avenue of being part of deaths that were meaningful, or that's something that the patient really would have wanted. And then when MAiD became legal, I actually volunteered to be part of MAiD team. And every single MAiD deaths that I witnessed have been beautiful in their own ways. There were some where the family members, when they were not on board, we actually had to send some family members away from one particular MAiD death because they were making that process hard for the patient who had chosen MAiD. But then I can tell you a story about a 90-something-year-old woman who there are several stages where the that the practitioner has to ask the patient to provide consent. And so at that final stage, when the physician said, is this really what you want? And she's, I don't know how many times I have to tell you that I've never been so sure about anything in my life. And so, and she had children, her grandchildren, everyone was in the room, and they were all laughing, but laughing through tears. And so were we who were part of that team. And I will never forget that moment. And I think that that woman is so lucky to have a death that she so believed in, and that she felt was death with dignity.
We're heading toward the close of the time. Did you want to tell a story, or should we? Because I think there are some additional questions that I feel we probably should try and answer, even if they're fairly short answers. The first one on my list is, will someone else be able to make a final decision for MAiD when it comes to mental illness, the change that we're all expecting in March? I think that's a very important factual question. We do expect that legislation will change next March, that mental illness as the sole underlying medical condition without a physical illness that is involved will become legal. And we're concerned because there's so many ethical and moral dimensions of it. But I feel fairly confident that it will never be a situation that someone else will be able to make that decision on behalf of the patient. And I think that's the conversation across the country at this point. So I think for those who are concerned that someone might make that decision on their behalf, that would not be the case. And I frankly can't imagine a healthcare professional agreeing to that kind of context. The second one is also an important factual question. Is MAiD being looked at for children? Laurel knows a lot about that.
Right now, MAiD is only legal for people 18 years and above. When MAiD first became legal, there was a stipulation that the government look at whether mature minors should be legal. The most recent federal report from a joint subcommittee said that not right now, but this is something we need to do some more research on. So it's still a potential in the future, but right now there's no tabled legislation that could subsequently allow mature minors to receive MAiD.
It is done in some other countries and jurisdictions where they deal with it in a different way. And I think where people are envisioning that possibility, the kind of patient they're thinking about would be the young teen who's lived most of their life with a form of cancer that's going to kill them, for example, and who feels that they want to be able to manage their death. I think that you know, where it's being considered, it's in a very limited context. Somebody's saying my question was next up, but it just got deleted as one of the two combined. I did see it. I don't think it got deleted. I think it got just dropped off my list, but I'll say it now. One of the speakers, I think this is Barb, mentioned the 3 reasons that people choose MAiD. One is pain, one's inability to care for oneself, and what's the third?
Great question. So the third is the inability to engage in activities that are meaningful for them. And so, as you know, we collect a ton of statistics on MAiD. There is a report produced every year that looks at all of the statistics across Canada. And one of the things that every assessor has to document is what are the reasons that this person is saying are their primary reasons for suffering, for choosing MAiD. And you'll hear things in the media that are just a little bit of a distortion of these statistics. So for example, you'll hear things like, well, you know, 17% of people are receiving MAiD because they're lonely, right? And that's a real misrepresentation of the statistics that are in the report. Essentially, people are choosing MAiD because of extreme suffering related to illness and a severe decline. Right? And that can result in loneliness. But that's very, very different than saying 17% of people are receiving MAiD because they're lonely.
Yeah, just important to remember that those patients, when they're answering, will have said yes to many of those conditions. Yes, I don't want to be a burden to my family. Yes, I'm lonely. Yes, I feel miserable because I cannot do the things that I value. Yes, I'm not being able to be myself. So the stories that people tell that lead them are multi-dimensional suffering. Next question. I'm confused about when to apply for MAiD. I'm healthy now, but would want MAiD if I'm suffering in the future. Do I apply now or in the future? Laurel, I think that's yours.
Right now, you can only apply and be determined eligible if you have a disease, illness, or disability, and then all those other subsequent things. So I think the best question for you, if you want to know if you're eligible for MAiD, you can find the MAiD request form, which is a government form. We can provide that information later, and then go through and look and see if those things that are listed on that request record are applicable to you right now based on how you feel about your health condition.
Carolyn, did you want to add to that? No, you're okay. Okay. In your research, is there hesitancy for men to participate in MAiD?
So it's a pretty much even gendered split when we look at the national data, which is pretty much the exact same across British Columbia. It's actually more women right now. It's 52% of women are applying and 48% of men. So it's pretty much right down the middle.
Okay, here's a Carolyn question. Can a patient have the capacity for informed consent when already on several narcotics at the end of life?
Yes, absolutely. In fact, there is a misconception that narcotics could cause capacity loss, but the opposite could happen as well. So if someone's suffering severe pain and or other symptoms, if they're not medicated well, then they may not be able to. And so it's important to be symptom-free as much as possible.
And I've been hearing about a new business of MAiD doulas who are able to administer the final dose. Is that legal? Okay.
I can just shake my head.
No, yeah, it is not.
But there are death doulas, so there should be a distinction. And death doulas are wonderful human beings, and they can be a very beneficial person to have involved in your end of life care. But they are not involved in administering the medications.
If a person requests MAiD, has not tried all the treatments available to them, as they don't feel this treatment will help and prolong their suffering, can they still be put on the MAiD trace?
Yes, if that person has seriously considered those options and the MAiD assessor feels like they've made that choice, not under duress, then absolutely. We're not forcing people to try chemotherapies that they don't want to. We're not forcing people to have electroshock therapy.
And how is the Dying with Dignity organization linked with MAiD? This is a consumer group of the public. It's a group that expresses the view of the public has been trying to advocate for options, including MAiD, for a considerable period of time. All of you can look online to see their materials. You can join it. It has healthcare professionals, probably people on this table would be part of it. It also aligns with those organizations in other countries who are trying to advance the legislation and advance these conversations. So it's a kind of consumer public advocacy organization that does include some healthcare professionals, but it is different from the Canadian Association of MAiD Assessors and Providers, which is the organization of those who are involved in the practice and research of MAiD, and they do not take a political perspective. Okay, track 1, then track 2 legislation. Does the new upcoming legislation have a name? It does have a name. It's called Mental Disorder as Sole Underlying Condition, but it is being managed the same as track 2. So the same eligibility criteria and the same kinds of processes. So it won't be called track 3. You can see them getting the message both sides. We're needing to move. As I said, we wouldn't be able to get to all the questions, but we've done a quick fire of some important ones toward the end, and some of us will stay around if we need to have some questions afterward. I want to move now for these few minutes, for a short time, into a research priority exercise. You know that we are engaged in research. from a patient and healthcare provider perspective on MAiD, the human experience of MAiD as it evolves in our country. And if you're on that Slido poll, feel free to go back into that Slido poll. For those of you who are sitting at tables with paper and pencil, feel free to write your thoughts. And for those online, you can certainly put something in chat. We want to ask you, in your opinion, what are the 1 or 2 key questions related to MAiD that you think researchers should try and answer in the next few years? You've heard a little bit about what we've been doing now. What do you think are the pressing questions we should be asking? So we just want to give you a couple of minutes to reflect on that and jot down your thoughts. Hoping some of you are busily writing questions. Well, I wish we could have answered all your questions. I have a feeling we could stay here until midnight and there'd still be more questions. But as I said, for those here in this space, that some of the panelists will stay to be able to talk to you individually if that's helpful. If you continue to have individual questions, please know that these are probably best managed by your own healthcare provider. So I hope you'll find your way to whoever you have available as a primary care practitioner or someone that can help you with your own situation and your own individual questions about what you might be eligible for or when. There is a link to the Health Canada information in this little card that you'll find in your bag. And we'd appreciate if those of you who are able to use a QR code to enter that QR code, and I think that takes you to your evaluation form. Am I right about that? Yeah. So that's what that looks like. And if you're sitting beside something, you've got a cell phone and sitting beside somebody who's a little bit more tech savvy than you are, they might be able to help you with that. There are also paper evaluation forms on the tables. We'd very much like to hear your thoughts about this session and how it was managed and how it was for you to be a participant in this session. As you're doing that, I'd like to acknowledge on behalf of all of us on the panel the gratitude we have for the wonderful busy people that have been moving around the room, making sure that you're all okay, that your questions have got into the box, that you have been able to get into the Slido if that's what you'd prefer. And we really appreciate these are individuals who are graduate students and others involved with the research, and we're greatly appreciative. Also like to I can't quite see her, but she's out somewhere. I'd like to give a special thanks to Helen Sharp, who has really been organizer. I'm proud of everything, the little bags that you've got on your table, and found this beautiful space for us to be in. Thank you all for the help that you've given, and we're very grateful. So thank you for coming and for your incredibly thoughtful questions. For those of you who posed questions, I'm sure there were 10 or 20 other people in the room who probably had the same question, so they thank you. CIHR, besides the evaluation, CIHR does want to have feedback. They're our funders, and we get to do these things again if they go well for the public. So we'd appreciate your feedback. And I'd like to end our session with tremendous gratitude to all of you for taking time out of your lives to come out on a weekday evening, to come to a place where you perhaps didn't know anybody and weren't sure what was going to happen, to be willing to listen to these enthusiastic researchers and practitioners who care so deeply about what they're doing and put so much thought into what they're doing, and also recognize it's an evolving and changing time in our country. I want to congratulate your courage for being here and showing interest in and speaking up about a topic that has been very difficult for so many people in Canada to get their heads around and to think about, and yet really seems to be meeting a need for Canadians to be able to talk about and plan for and manage the end of life. We all know we're all going to die sometime, and many of us do feel that we'd like to be able to have more voice in how those endings take place. And I think this time we've had these last few years have allowed Canadians to talk with one another, with their friends and family and neighbors, to clarify their own thinking, to write down their own wishes, to express their values to those who might be around them at the time that they need to make those decisions at the end of life. And I'm hoping these conversations we have are helpful to you as you go through that process. So Barb, I wonder if you feel that you'd like to say a few closing words before we let everybody go.
Oh, I just want to echo Sally's comments. Thank you so much for coming tonight. It has been a real privilege to have you. And thank you to our speakers who've done such a good job and for all the work that you do. So go safely tonight. Thank you again. We will stay behind if you have any questions or comments. Thanks.